Alemtuzumab, CAMPATH. Indication: T-cell prolymphocytic leukemia, TPLL. PRE assessment. 1. Record stage of disease, CT scan, neck, chest, abdomen and pelvis, presence or absence of B symptoms, clinical extent of disease, bone marrow aspirate and trophine. 2. Blood tests, CMV serology, CMV PCR, hepatitis B core antibody and hepatitis B surface Ag, hepatitis C antibody, EBV, VZV, HIV after consent, TP53 mutation analysis, FBC, biochemistry and glucose. 3. ECG plus/echo if clinically indicated. 4. Record performance status. 5. Record patient's height and weight. 6. Urine pregnancy test, before cycle 1 of each new chemotherapy course for women of childbearing age unless they are postmenopausal, have been sterilized or undergone a hysterectomy. 7. Consent, ensure patient has received adequate verbal and written information regarding their disease, treatment and potential side effects. Document in medical notes all information that has been given. Obtain written consent on the day of treatment. 8. Hydration, in patients with bulk disease prehydrate with 1 liter sodium chloride 0.9% over 4 to 6 hours. Patients at high risk of tumor lysis refer to tumor lysis protocol. Assess and document tumor lysis risk as part of pre-assessment. 9. Contact local blood transfusion lab and inform of the need for indefinite irradiated blood products following the administration of alemtuzumab. Ensure irradiation card is attached to the patient's notes. 10. Treatment should be agreed in the relevant MDT. Drug regimen. Pre-medication. Chlorpheniramine 10 mg intravenous and paracetamol 1g oral, and hydrocortisone 100 mg intravenous 30 minutes before the first dose and with each dose escalation, thereafter as clinically indicated. Week 1. Intravenous alemtuzumab is given at the dosage level outlined below as an infusion. Wednesday, alemtuzumab 3 mg intravenous. Thursday, alemtuzumab 10 mg intravenous. Friday, alemtuzumab 30 mg intravenous. Weeks 2 to 12. Mondays, alemtuzumab 30 mg intravenous. Wednesdays, alemtuzumab 30 mg intravenous. Fridays, alemtuzumab 30 mg intravenous. Dilute in 100 ml sodium chloride 0.9% and infuse over 2 hours. If acute moderate to severe adverse reactions due to cytokine release, hypertension, rigors, fever, shortness of breath, chills, rashes and bronchospasm, occur at either the 3 mg or 10 mg dose levels, then those doses should be repeated until they are well tolerated before further dose escalation is attempted. Duration of treatment. Minimum 4 weeks. Maximum 18 weeks of treatment. Consensus guidelines. If disease is progressing, discontinue treatment. If disease is stabilized or responding, continue for 6 additional weeks. If there is no further clinical response, i.e. a plateau, over a period of 4 weeks, discontinue treatment. If complete response in blood and nodes, check bone marrow every 4 to 6 weeks, then continue alemtuzumab until complete marrow clearance or no further response. Unless contraindicated, treatment should be carried out to a maximum 16 weeks. CMV reactivation. If CMV PCR blood testing indicates CMV reactivation, see guidelines on management of CMV reactivation. Dose modifications. Alemtuzumab, if treatment is delayed for more than 7 days, it should be reinstituted with the dose escalation from 3 mg. Anemia. For anemic patients, alemtuzumab may be given with transfusion or erythropoietin support. Transfusion support should be with irradiated blood products. Thrombocytopenia. If platelets less than 25, but no hemorrhage, administer full dose. Transfusion support should be given as required, e.g. platelet count less than 10. In the event of hemorrhage, stop alemtuzumab and reinitiate when bleeding has stopped. Neutropenia. Clinical judgment should be used for institution of GCSF when ANC drops to 0.5x109L. Cytopenias are likely to resolve spontaneously and support may not be needed. Temporarily discontinue alemtuzumab if ANC less than 0.25x109L. Temporarily interrupt therapy in the event of febrile neutropenia. Reduction in alemtuzumab dose is not recommended. Infusion-related toxicity. If there are no adverse events with the first dose of alemtuzumab, the dose may be increased the next day. If any infusion-related reactions do occur, administer the same dose the next day. Only escalate the dosage once the patient has become tolerant. Renal or hepatic impairment. No data. Discuss with consultant. Adverse effects. Regimen-specific complications. Rigors develop during the first few injections. Infusion-related fever more common during the first week and commonly begins 5 to 6 hours after the infusion starts. Hypertension, dyspnea, rashes, headache and diarrhea. Thrombocytopenia most common during weeks 2 to 4 and neutropenia common between weeks 4 to 8. Management of adverse events. Small black square hydrocortisone 50 to 100 mg intravenous may be given pre-treatment in the event of continued infusion-related toxicity. Small black square. If rigors develop, halt infusion and administer intravenous chlorpheniramine. Small black square in patients experiencing rash, an additional 4 mg chlorpheniramine PO every 4 to 6 hours as needed is indicated. In patients experiencing severe rash, premedication with H2 receptor antagonist, e.g. famotidine, is recommended. Small black square treating physicians are advised to use antibiotics and GCSF support according to their clinical judgment for febrile neutropenia. Small black square. If hypertension develops, hydration with normal saline is indicated, unless contraindicated based on underlying cardiac status. Small black square. If dyspnea develops, infusion should be stopped and treatment with inhaled beta-2 agonists should be administered if needed. Severe dyspnea may require the temporary use of steroids. Thank you. www.hematomorph.com